My name is Fiona Fantasy. I'm a radiologist at the Brigham and Women's in Boston, and I'm a fellow of ICIS. And it is my pleasure to moderate today's webinar featuring lung thoracic oncology imaging update. Before we get started, I'll introduce the speakers in a second. Before we get started, I just wanted to thank our corporate sponsors, Siemens. I wanted to remind people to sign up for the monthly ICIS e-newsletter. You can learn about these webinars, all the different courses that we have going on, articles published in cancer imaging and much more. And you can either do that through the QR code or else you can do that online as well. Hopefully, many of you have registered for the ICIS and SGCR Wires conference that's taking place in September in Singapore. The early bird registration is now open. In addition, I want to remind you and any trainees that you may have or people that you work with that the abstract deadline is coming up. It's the end of this month, so May 31st, 2024. And the program is set if you want to check online. It's a really, really good program and a great place to have this meeting. Just a little update on cancer imaging. The impact factor is now 4.9, which is really high. The timeline to decision making is also decreased. It's 14 days. And the joint editors, as you know, are Rodney Hicks and Anita Dana-Farber. So if you're interested in reading any of these articles or hopefully in submitting articles, please go to cancerimagingjournal.com. Just a quick word on the ICIS masterclasses. So for those of you who are not familiar, these are interactive workshops with small groups. So a small group of people, it's almost like one-on-one training, if you like. So you can email the admin at Cancer Imaging about this for your, if you're interested in participating in these potential masterclasses. So again, these are interactive and quite small. So just to introduce our two speakers, we have my friend and colleague, Dr. Mizuki Nishino, who works with me at the Brigham and Women's Hospital. Mizuki is a professor of radiology at Harvard Medical School and a well-known expert in cancer imaging. And co-presenting with Mizuki today, we have Dr. Luba from Baylor College of Medicine, and she's an associate professor at the University of Texas. So I'm going to hand this over to Mizuki's going to start. And if you have any questions, we're going to take questions at the end of the session. You can put them in the chat. You can try the Q&A. Not sure it's working, but the chat's a safe bet, and I will collect questions. So over to you, Mizuki. I'm going to stop there.
Thank you very much, Fiona, and good morning or good afternoon, or maybe good evening, depending on where you are across the globe. And it's my great pleasure to talk about imaging of lung cancer precision therapy for this ICIS webinar. These are my disclosures. And before going into the details of each item for this talk, I would just give a quick overview of what we call lung cancer precision therapy in the context of this talk. So there are mainly two domains. One is molecular targeted therapy. It's more like a conventional targeted therapy, or what we call precision therapy. And here the target is oncogenic driver mutations in cancer cells and that causing cancer to proliferate and making them into cancer cells. And so those drivers are, as listed here, such as EGFR, ALK, KRAS, HER2, and BRAF, and there are corresponding effective agents that specifically targets those oncogenic drivers in cancer cells to suppress their proliferation, and that's how they work. The other domain, relatively newer domain, is this immune checkpoint inhibitor therapy, where it is also a targeted therapy towards specific molecules, but here the targets are immune checkpoint molecules at the interaction of tumor cells and immune cells that regulate the host T cell immunity against cancer. And molecules as listed here, such as PD-1, PD-L1, and there are a number of agents that has been already approved and used in the clinical setting. And in both of these therapies, imaging plays a critical role to assess tumor response and progression, as well as diagnose and monitor therapy-related toxicities. So with that in mind, in the next 25 minutes or so, I'd like to first go over imaging of molecular targeted therapy, then move on to imaging of immune checkpoint inhibitor therapy, and then finish with imaging of therapy-related toxicities focusing on pneumonitis. So first about molecular targeted therapy, as many of you are aware, discoveries of genomic abnormalities specific to lung cancer in the past decades have completely transformed the way how oncologists approach and treat patients with lung cancer. One of the representative examples is this epidermal growth factor receptor, or EGFR mutations in lung cancer that are associated with a dramatic response to EGFR inhibitors as listed here. And then when we use these agents to a specific patients with lung cancer with EGFR mutation, this is what we see on imaging, mostly using CT scan. This is a patient with adenocarcinoma of the lung with sensitizing EGFR mutation on its exon 19, showing a large dominant mass in the right lung with innumerable metastatic nodules at the baseline. Patient was treated with EGFR inhibitor allotinib, and after 2 months of therapy, the primary mass shows significant shrinkage showing response to therapy, and the majority of metastatic nodules have mostly disappeared. And in this particular patient, the response is durable over 2.5 years, and after 2.5 years, she remained progression-free with very minimal residual tumor burden at the site of primary tumor in the right lung. And so this is how dramatic the response is when this type of agent is used in the right population. However, there is a problem. The major problem of this type of single agent targeted therapy for advanced lung cancer is acquired resistance, which means that these tumors that are originally very sensitive and responding to this agent become resistant to this agent because they acquire new characteristics, mostly a new type of mutation or second site mutation in their receptor, so that they can be able to grow and proliferate, survive and grow and proliferate, and therefore recur even in the presence of this agent. And this is what we see on imaging for this setting. So this is another EGFR mutant lung cancer patient with a dominant speculated mass in the right lung, treated with EGFR inhibitor allotinib and shrunk after 2 months, showing response to therapy. In this case, the response was durable over 3 years or so, but after 3 years, tumor started to gradually go back and later grow much more, and this is due to acquired resistance. And the biopsy at 44 months showed the presence of second site T790M mutation of EGFR, which is the responsible for majority of acquired resistance cases for these conventional EGFR TKI. Therefore, the efforts in the thoracic oncology in the past decade was how to overcome those acquired resistance, and for that, several new agents has been developed and tested, and the most effective agent that has been approved and used widely now in the clinical setting is called osimertinib, one of the third-generation EGFR TKI that can specifically target the acquired resistance T790M mutation as well as the sensitizing EGFR mutation while sparing the wild-type EGFR. And this is one of the examples how effective this agent can be in patients even with acquired resistance with recurrence. So this is another stage 4 lung adenocarcinoma patient with EGFR mutation, sensitizing mutation at the beginning, treated with allotinib before, responded but recurred after a few years, and now she's has this large recurrent mass in the right lung before starting osimertinib therapy. So this is a baseline before starting second-line osimertinib for this tumor with acquired resistance. The patient was treated with osimertinib, and tumor shrunk, as you can see here, after 1.5 months, showing a significant response. And the tumor further decreases and reaches a nadir over a year or so. So this is how effective this agent is, even for tumor with acquired resistance. However, as you see down the line, if you keep going with this therapy, the tumor grows back again after 2 years or so. And this is due to the development of further acquired resistance that making this tumor now resistant to this new agent osimertinib due to new mutations or new molecular characteristics or biological characteristics that the tumor acquire. So in a sense, this phenomenon continues, the tumor shrink and come back and shrink and come back as long as we are going with the single agent targeted therapy. However, considering this is a stage 4 lung cancer at the beginning with few years of disease control before this and another 2 years of progression-free time, this is a significant advance. And this agent osimertinib has been also shown to be effective as a first-line therapy for sensitizing EGFR mutant tumors, and therefore become the agent of choice for these patients. So this is how we approach lung cancer today, and this is EGFR is one of the examples. However, it's not the only one. There are multiple molecules and targets with effective agents, and this is how we look at, in this case, lung adenocarcinoma, classify them according to their oncogenic drivers, and perhaps the most notable advances recently is this approval of this KRAS inhibitors, specifically targeting G12C mutation, which consists of a subset of this big chunk of pie of KRAS mutant that occupies about a quarter of lung adenocarcinoma. So this is how far this precision lung cancer therapy came along, and with that in mind, I'd like to talk about imaging. So the role of imaging in this type of advanced lung cancer targeted therapy is mainly tumor response assessment, and for that we have standardized criteria using imaging starting from WHO criteria published 4 decades ago. Later in 2000, response evaluation criteria in solid tumors or RECIST has been introduced, revised in 2009, and it uses unidimensional longest diameter measurement. And RECIST has quickly incorporated into majority of the solid tumor clinical trials, including lung cancer, and has become the standardized criteria, and therefore provided the basis for FDA and regulatory approvals of new agents. Both WHO and RECIST assign 4 categories of responses as shown here, and each criteria has a specific cut point to define response and progression, and notably, appearance of new lesions define progression for both for RECIST and WHO. And although these criteria, particularly RECIST, is widely accepted and quite practical to define response and progression and assess the novel agents, there are some issues for these criteria, particularly when it is used for this type of novel precision therapy. One of the major issues of using RECIST for molecular targeting therapy in lung cancer is slow tumor growth and treatment decisions beyond RECIST progression when they start slowly growing after initial response. And I'll show you an example. This is another EGFR mutant advanced lung cancer with a large dominant mass in the left upper lobe at the beginning. Patient was treated with a losnib EGFR inhibitor, and tumor responded very well and reached the nadir after a year or so. Now, once you reach the nadir after initial response, the nadir is the smallest tumor burden since the baseline. This nadir becomes a reference point for comparison to define progression. And therefore, for this case, when the patient started to grow gradually due to acquired resistance, you compare with this, and any increase over 20% and 5 millimeter increase compared to this meet the RECIST 1.1 progression. And actually, this much increase is actually meets the criteria for RECIST 1.1 progression. However, nobody thinks it's time to change therapy for this tumor like this big at the beginning, and therapy has been very effective. Therefore, the therapy kept going. And in this particular patient, the tumor grew back this much, and the patient also developed this new leptomeningeal metastasis. This is when the therapy was changed. Now, this is before the approval of osimertinib in the era of erlotinib. However, as we saw, even with these new agents such as osimertinib, we see these tumor shrinkage and then subsequent growth due to acquired resistance. So this is still a pertinent issue in precision lung cancer therapy today. And for that, our group has focused on CT tumor volume analysis as a more accurate and objective measure compared to diameters used in RECIST. And we can characterize tumor volume dynamics in these patients during precision therapy. And most patients show these quite characteristic dynamics. This is an example of representative example from one patient. The most patient has this large tumor burden at the baseline, as you can see here, and tumor shrink after starting effective targeted therapy. And initial shrinkage is mostly the for the most part, it's the biggest shrinkage, which happens around 8 weeks. Tumor may shrink further down and reaches nadir around 6 to 12 months of therapy, and it may stay stable at the nadir for a while, but it gradually comes back due to acquired resistance, and later it grows much faster. we have evaluated this tumor volume dynamics as a predictor of clinical outcome, and we have shown this initial 8-week increase is a predictor of longer overall survival. But we have also focused on this tumor growth after nadir and came up with a way to characterize or assess and quantify the tumor growth rate after nadir, how these tumors grow at which rate while they are on therapy. And now we are working on to develop an analytic module which can instantly display and analyze tumor volume dynamics for, during precision therapy and calculate the tumor growth rate, which can work as a predictor of overall survival after nadir in this population. So this is about precision therapy, and in the latter half of my talk, I'd like to move on to imaging of immune checkpoint inhibitor therapy. As many of you know, immune checkpoint inhibitor therapy, or ICI, has really become a major treatment option for advanced cancers, including lung cancer. And it has a very unique anti-cancer mechanism where it works via blockade of immune inhibition by tumors. And what it means is when there are tumor cells express those molecules such as PD-L1 that binds to the receptor on host T cells such as PD-1, and through this binding, it sends inhibitory signal to suppress activity of host T cells so that they can survive and proliferate and escape immune attack. What immune checkpoint inhibitors such as PD-1 or PD-L1 do is to block this binding, thereby activating the host T cell immunity so that they can recognize and attack tumor cells. And because of this unique mechanism of action, this agent ICI can be very effective in some patients, including lung cancer, like in this patient with advanced lung cancer with very aggressive looking heterogeneous tumor occupying the bilateral hilum with a large dominant mass in the left lower lobe. She was treated with nivolumab, the PD-1 inhibitor, and after 1.5 years, the patient has showed this significant shrinkage of the tumor with very durable response. So this is how effective this agent can be in some population. However, unfortunately, not all patients receive this much of a treatment benefit from ICI, and therefore the major effort today in immuno-oncology for lung cancer is to come up with an effective biomarker for better patient selection. And for that, PD-L1 expression in tumor cells by immunohistochemistry has been already used in the clinical setting, but there are many other candidates that are being tested and brought to the clinic to achieve truly precision immunotherapy. And imaging also plays an important role for tumor response assessment during ICI therapy, because in patients who is treated with ICI during the early clinical trials, starting with melanoma, unconventional response patterns were noted, which included response after increase in tumor burden, as shown here in the case of metastatic lung tumor, and response during or after appearance of new lesions, as shown in this patient with melanoma who developed this new subcutaneous nodule after starting therapy, though it goes away after another cycle without starting therapy, without changing therapy, showing a pattern of immune-related response. And because of both initial increase and appearance of new lesions meet the criteria for resist progression, these patterns are often called pseudo-progression. Many effort has been made to modify response assessment criteria to capture those immune-related atypical response patterns. Starting from IRRC in 2009, our groups published several experiments that formed the basis to go with RECIST-based assessment with several modifications in 2013, now called IR-RECIST, and more recent development is iRECIST, published by RECIST Working Group. But basically, the overall consensus is to use RECIST-based measurements and assessment with necessary modifications to capture immune-related response. Now, several important things to note when we look at these immune-related responses and pseudoprogression, which is acquiring a lot of increasing awareness in both radiology and oncology, it is important to note the instance of pseudoprogression. Pseudoprogression is a rare event. Instance rate is only up to 10% or less in melanoma, 6% in meta-analysis of ICI trials for various solid tumors, and 5% in trials of lung cancer with PD-1 inhibitor. And in our studies of patients who are treated in the clinical setting as a standard care, the pseudoprogression was only 1% or less. And therefore, it is a very rare event, particularly in lung cancer. And that means if you're looking at tumor burden increasing, a patient with lung cancer on ICI, you're most likely looking at true progression than pseudoprogression, unfortunately. Another important phenomena that has been described is hyperprogressive disease, where basically the tumor burden increase accelerates after starting ICI therapy compared to the period before, and it can be seen up to 10% of the patient, and it includes lung cancer, and this emphasizes the importance of robust biomarker for better patient selection to maximize benefit of ICI therapy. And for these ICI therapies, it's also important to look at the tumor burden dynamics. In this case, we used RECIST, but we have studied several different cohorts of lung cancer patients, and we have discovered that tumor burden staying below the initial baseline tumor burdens during therapy is an indicator of better prognosis with longer clinical survival. Now, moving on to the last part of the talk to finish up therapy-related toxicities. Continuing on the theme of ICI therapy, the ICI therapy is associated with a wide variety of toxicities that can affect organs literally from head to toe, as shown here. And imaging plays an important role in detection and diagnosis and monitoring in many of these toxicities, but today we focus on pneumonitis. Because ICI pneumonitis is relatively rare, but clinically serious and potentially life-threatening toxicity. The incidence rate is about 3% in PD-1 monotherapy trials, and it doubles when PD-1 is used in combination with other immunotherapeutic agents. Incidence is higher in lung cancer compared to other tumors, and it is also shown to be a leading cause of anti-PD-1, PD-L1 related deaths, accounting for more than 1/3 of these deaths, again emphasizing the clinical severity of this toxicity. Imaging plays an important role in detecting, diagnosing, and monitoring, and potentially prognosticating these ICI pneumonitis. And CT, on CT, you see a variety of patterns or spectrum of patterns of pneumonitis manifestation that almost encompasses a full spectrum of patterns that has been originally described in the setting of idiopathic interstitial pneumonias, as shown here. And these patterns also correlate with clinical severity reflected by CTCAE toxicity grades, and therefore it can help guide patient management. I'll show you some example from here. This is a patient with melanoma treated with nivolumab PD-1 inhibitor presenting with severe shortness of breath at 15 weeks of therapy. The CT scan shows this diffuse ground-glass opacity in both lungs with significant traction bronchiectasis bilaterally and significant volume loss of the lung. This is one of the most severe patterns that needs to be recognized right away, called AIP-ARDS pattern, sometimes also called DAD pattern, diffuse alveolar damage, reflecting the presumed histology of this entity. These are the ones that can cause very serious, sometimes fatal clinical consequence. This needs to be communicated to the referring physician right away. And this particular patient had to be intubated in MICU and received high-dose immunosuppression in addition to steroids. However, in some patients, ICI pneumonitis can be pretty mild, like in this case. Of another melanoma patient presenting with mild dyspnea, the CT shows this mild interstitial lung abnormalities at the periphery of the lung, showing NSIP pattern. In this patient, in this particular patient, the pneumonitis could be treated as by oral corticosteroid as an outpatient basis, and patient could complete entire 2 years of nivolumab therapy and remain progression-free and pneumonitis-free. So this is how mild pneumonitis can be in some patient. Now, as we accumulate our experiences, we noted that this is the most common pattern, an OP pattern or organizing pneumonia pattern, like in this case of patients with lung cancer treated with nivolumab. CT scan shows the patient presented with severe cough and shortness of breath, but no fever at 15 weeks of nivolumab therapy. CT scan shows these multifocal consolidative opacities predominantly in peripheral portion and the lower portion of the lungs. And of course, the clinical question from thoracic oncologist in this patient with advanced lung cancer is, could this be a tumor progression in the lung? And for that, it is important to look at the original manifestation of lung cancer as well as how the other metastatic sites are doing. Another important differential is, of course, multifocal infectious pneumonia, including COVID-19 pneumonia in the current era. For that, clinical assessment is necessary. In this case, both the clinical and radiologic manifestation was consistent with ICI pneumonitis with an OP pattern, and patient responded to steroids very well. However, 4 weeks after completing steroid taper without restarting ICI or any other systemic therapy, same pattern of pneumonitis came back with cough and shortness of breath, with no fever, with those multifocal consolidation with OP pattern. This is a pneumonitis flare where ICI pneumonitis comes back without re-challenging ICI or starting any other systemic therapy. And this also responds to steroids pretty well. However, this shows how complicated the clinical course can be in some patients. Important pitfall, particularly for a lung cancer patient, is the pneumonitis from ICI plus radiotherapy, which is an already approved treatment for stage 3 lung cancer. And in this case, the manifestation and imaging can be slightly altered, particularly in the distribution, because previously irradiated lung has higher propensity to develop these opacities due to pneumonitis, and therefore distribution could be altered. Finally, targeted therapy agents can also cause pneumonitis, and among many other agents, one new thing to note in new agents that to be aware of is this antibody drug conjugate called trastuzumab deruxtecan, or TDXD. This is an antibody drug conjugate of HER2 inhibitor and topoisomerase 1 inhibitor that has been used for breast, gastric, and lung cancers as well. It's already an approved agent, and it is associated with a high incidence of pneumonitis, as shown here in lung cancer. Recent trial of lung cancer, about a quarter of patients developed pneumonitis, including 2 fatal cases. And therefore, recognition of pneumonitis in patients treated with this new antibody drug conjugate is very important. So in conclusion, molecular target therapy and immune checkpoint inhibitor therapy consist of major advances of lung cancer treatment in the past 2 decades, and imaging plays an essential role in monitoring treatment response and toxicities. Thank you very much for your kind attention.
Thanks, Mizuki. Luba, do you want to screen share?
Well, good morning, everyone. It's morning in Texas. I'm Luba Frank, and I will present an overview of pulmonary infections in cancer patients. I work at Baylor College of Medicine, Baylor St. Luke's Medical Center at the Texas Medical Center, one of the largest in the world. And it is a pleasure to be here. I have nothing to disclose for this talk. And the objective, we're just going to review underlying pathophysiology processes really quick causing pulmonary infections. So we're focusing on a few ones and discuss some fungal infection in immune-compromised patients and viral and atypical bacterial infections as well. So when we talk about pulmonary infections in cancer patients, these are significant cause of morbidity and mortality. This is the number of cancers, the incidence of cancer increases, and the bone marrow transplant patients also increase. The incidence of serious pulmonary infection also increases. So interesting to share that the organism most likely to cause infection will depend on which arm of the immune system is defective, and I'll go over that as well. And not only which part of the immune system is defective, but also on the local factors, such as disruption of function of the local mucociliary clearance system, as well as normal function of the bronchial surface fluid and epithelial lining cells. So we are talking about 3 major factors, such as neutropenia, T lymphocyte dysfunction, and B lymphocyte dysfunction. Each of them linked into the certain causes. Majority of them are overlap. such as chemotherapy and BMT, but also more specific ones as the myeloproliferative disorders resulting in neutropenia, solid organ transplant, and long-term steroid use for T lymphocyte dysfunction, and lymphoproliferative disorders for the B lymphocyte dysfunction. And all of those are linked to a certain infections. Again, most of them are overlap, but some of them are more specific, such as fungal infection and viral infections that are more commonly seen in T lymphocyte dysfunction. So let's talk about neutropenia. Neutropenia, particularly after cytotoxic chemotherapy, it considered as a granulocyte count is less than 1,000 per, and the risk increases as the count falls below 500, and particularly greatest when it's less than 100. So patients are most susceptible to bacterial infections in the early neutropenic period. That's when we see those infections, bacterial infections, strep, staph, and these are really difficult to tell apart from the other ones or usual community-acquired infections. Talking about defects in humoral and cellular immunity, humoral immunity is mediated by B lymphocytes, and those are particularly seen with lymphoproliferative disorders following chemotherapy, bone marrow transplant patients. And then again, those we see infections with encapsulated organisms such as strep, gram-negative organism, Haemophilus influenza, Neisseria, and Pseudomonas, etc. And those are tough to distinguish from the community-acquired pneumonias. T-cell dysfunction is a cellular immunity mediated by T lymphocytes, and it affected in patients with lymphoproliferative disorders as well. Also patients receiving chemotherapy, bone marrow transplant patients, are particularly important, solid organ transplant patients, and patients on long-term steroids. So, and this is a group that I will be focusing on, and I will show you some cases that are of the atypical viral and fungal pneumonias as well. So specific point I wanted to make about the bone marrow transplant patients, those patients undergo high-dose chemotherapy designed to eradicate malignant cells from the endogenous bone marrow. Then they get into the profound immune impairment following bone marrow transplantation with severe neutropenia that lasts for 2 to 3 weeks after the transplant. And that can continue up to 4 to 5 months. So we're talking here about the 4 to 5 months of severe impairment, immune impairment, with a full recovery gradually restored over the course of 1 year. So fungal pneumonias are a major cause of death in immunocompromised patients. Opportunistic infections, most commonly seen Aspergillus, Candida, Cryptococcus, and Mucor, and those occur in neutropenic patients, and I'll show you the examples of those. Not only that, but also with a profound neutropenia, with a profound immune deficit, those patients develop reactivation of indolent infections with organisms such as Histoplasma, coccidioides, and tuberculosis. So let's start with the aspergillosis or Aspergillus infection has been reported up to 20% of bone marrow transplant patients. It is a very well-known infection that we see relatively often with prolonged neutropenia, steroid therapy, broad-spectrum antibiotics, transplantation of the T-cell depleted marrow, all predisposed to the patient with Aspergillus infection. Mortality is high, reported to be up to 60% and in neutropenic patients, and up to 90% in bone marrow transplant patients. Now, it is very important what is the immune status of the patient to understand the morbidity and mortality and those percentages as well. So when we're talking about severe immune suppression, then we're talking about the cases of invasive aspergillosis, which is the most deadly with a mild immunosuppression. These are the cases of semi-invasive aspergillosis, and those normal and hypersensitivity immune status we're not going to cover today, but these are also the types of aspergillosis that can be found in the organisms. A very similar graphic presentation here with severely immunocompromised patients with both the invasive aspergillosis, etc. So what is aspergillus? Aspergillosis is the conidiophores, reproductive form spores with a hyphae. These are the hyphae, dichotomous hyphae. They're found in soil and water and in decaying organic materials. And it has these 4 forms that I've already touched. Invasive aspergillosis, severely compromised patient. Inhaled spores germinate into hyphae. They sit in the within the bronchi, they proliferate, release proteases and transbronchial pulmonary arterial invasion, and they cause thrombosis, infarction, hemorrhage, and cavitation, and that's what we're seeing in invasive aspergillosis. On imaging, we see multiple patchy peripheral, usually ill-defined nodular opacity. It could be callous and confluent, very typical or mostly typical halo sign on CT. That consists with hemorrhage. Most of the, or 50% of the nodules will cavitate, and they can also exhibit air crescent sign that shows that the lung is necrotic. So here are the examples of those cases. This is the patient with ALL with the 2 days interval chest radiographs. We're looking at the radiograph on the left here with this patchy airspace opacities that look like pneumonia to us. Maybe there's a little bit on the right as well, but within 2 days there's a severe degradation, and there's a confluent callus and opacities that have developed, and patient has been intubated. This is a patient with invasive aspergillosis. Talking about this coalescent nodular opacities with a halo sign, this is ground glass attenuation surrounding those nodules or this confluent nodule. And then on the pathology, that all you can see is this is the area of angio invasion right here, and that corresponds to the ground glass component of those opacities. Looking at the cavitary nodules, those nodules up to 50%, as we said, can cavitate. And then this is a crescent sign, and this is air that's trapped within that cavity between this soft tissue or fungus and necrotic tissue and a little bit of air. Here you see that air on the right. Here's another oral companion case of angioinvasive aspergillosis in 46-year-old male with history of chronic lymphocytic leukemia. He did have bone marrow transplant, and sputum cytology revealed angioinvasive pulmonary aspergillosis. Looking at this, at his imaging, we can see those mass-like or nodular, ill-defined or speculated masses in both lungs. They're randomly distributed. Some of them are larger and confluent, and there's a clear ground glass component or a halo sign surrounding those lesions. So this is HRCT 7 weeks later following an antifungal treatment. There's definitely a decrease in size of pre-existing multiple pulmonary masses, and nodules still there's a way to go. But this is the case of proven angioinvasive aspergillosis. Now, just as a matter of time, the semi-invasive aspergillosis, I'm not going to show you cases, but with the immunocompromised patients that are mildly immunocompromised, we can see less dramatic presentation of aspergillosis. There's some, could be some underlying structural disease, usually progressive upper lobe consolidation, may cavitate. They're persist longer. They could be up to 5 to 7 months, and then appearance is similar to tuberculosis. This is one of the cases that I have to show you. Looks like tuberculosis. This is actually non-invasive aspergillosis with aspergilloma or mycetoma. We can see the crescent air sign right here. It's a relatively old case, but very representative. So another disease that that we can see in immunocompromised patients, severely immunocompromised patient, fungal infection and candidiasis. So Candida albicans, blastospores. Normally, it can be found in GI tract and upper respiratory tract. It is an opportunistic invader in immunosuppressed patients. Most of the signs that are being involved are mouth and esophagus. However, pulmonary involvement can be seen in aspiration pneumonia, the acute bronchopneumonia with patchy lower lobe airspace consolidation, which is sometimes hard to tell if this is just a regular respiration pneumonia for another reason, or that is a candida. So there's also a hematogenous dissemination of candidiasis with a multiple randomly distributed nodules. Those can cavitate, and there could be a lymph node enlargement, but it is rare, and it is associated with multi-organ involvement. Here's the involvement of the lung parenchyma, multiple nodules, as we see, they're ill-defined. I hope you can see my mouse. So multiple nodules, they're random, they're mostly along the pleural surfaces, and non-calcified, numerous nodules. Now here's the dissemination or involvement in the abdomen. Sometimes really hard to tell apart if we're talking about sarcoidosis in the abdomen, because in the sarcoid, you can also have the involvement, nodular involvement of the liver and the spleen. In this particular case, this is very small. These are numerous small nodules, and this is the systemic candidiasis. A next condition that we move on to is the cryptococcus neoformans, and the synchro-binding yeast with a thick capsule, and found in soil, particularly contaminated by pigeon droppings. In the normal, in immune competent host, that's what we could see. We could see mass-like opacity, focal peripheral opacity. Sometimes hard to tell what that is, and it could be could look like a lung cancer, or it could look like a pulmonary infarct as well. However, in immunocompromised hosts, we see disseminated disease that it could cause meningitis and CNS involvement. Chest radiograph can be normal despite disseminated disease because of the small size of the lesions. We can also sometimes see interstitial pneumonia or military pattern. And in this particular case, it can be difficult, excuse me, to distinguish between tuberculosis or histoplasmosis. Now moving on to mucormycosis. This is really a deadly and a really bad disease, angioinvasive, similar to invasive aspergillosis. It causes, excuse me, arterial thrombosis, hemorrhage, infarction, and necrosis. However, it is much more aggressive, and it does not respect any anatomic boundaries. It just goes through the tissue, no matter soft tissue or the bone. On imaging, we see consolidation, nodules, cavitations. It's a multi-systemic disease. Or we can see apparently exocytes involvement as well. This is very characteristic for mucormycosis. Here's an example of patient with AML with a very large consolidation that extends from the hilum toward the pleura. Again, seeing patient with AML with nodules with halo sign, and that is sometimes, that's why it's difficult to really distinguish between invasive aspergillosis and mucormycosis. So the next, just a moment. The next condition we're moving on to is pneumocystis and is PJP. PJP is another tricky disease that could be difficult to diagnose clinically. Here's an example of a 54-year-old male with desaturation exertional dyspnea, history of bone marrow transplant, and that was confirmed, the diagnosis was confirmed by sputum pathology. So initial HRCT, we can see very characteristic or characteristic for PJP, but non-specific for a non-specific areas of ground glass attenuation in both lungs, and these are usually upper lobe predominant. There sometimes we can see the interlobular septal thickening as well. Those are a little irregular, so we can see them in both lungs. It is a serious, life-threatening infection in an immunocompromised patient, difficult to diagnose clinically, as I said. X-rays may be normal or equivocal. HRCT has high sensitivity and specificity when presence or absence of ground glass opacity is taken as a criterion for PCP or PJP infection. In other words, if you think about it and you see that picture, these pictures, then that could be highly specific, sensitive and specific. So those opacities are very highly, they're ground glass. They're seen in more than 90% of the patients, and sometimes they can interlobular septa as well, and parenchymal cysts. So we used to say that parenchymal cysts are one of the pathognomonic features of the PJP, and these are actually seen in a relatively low percentage of patients. So if we don't see the cyst, that does not mean that that's not the PJP. So this is a follow-up study on the same patient. It was performed 6 weeks later after treatment. And we see significant or dramatic improvement of those ground glass opacities in both lungs, and really no cyst formation. So the next condition we're moving on to is a cytomegalovirus pneumonia, or CMV. This is an example of 61-year-old man with Burkitt lymphoma, 40 days after bone marrow transplantation, now with fever and cough. Remember, I mentioned that those profound neutropenia patients after bone marrow transplantation can last up to 4 to 5 months, particularly first few weeks. This is also confirmed sputum cytology, CMV. And look at the presentation on the HRCT. So we see, again, very similar, but maybe more dramatic areas of ground glass opacities in both lungs. Those are in the left upper lobe, and then there's some also nodularity, those fuzzy nodules, and some ill-defined, more of a nodular and patchy opacities with some nodules with fuzzy margins. And this is 4 weeks later with significant or markedly worsening appearance of the lung parenchymal abnormalities and accumulation of bilateral pleural effusion here, left greater than right. Again, we're seeing those fuzzy nodules that appear confluent. So there's definitely a worsening. So this is typical for CMV. It gets worse, it gets more confluent, and the patients are pretty sick. So usually or commonly seen CMV pneumonia seen in AIDS. Or after bone marrow transplant or solid organ transplant, really typical appearance. Clinically, CMV and PCP or PJP infections have very similar population, very similar clinical presentation, and radiologically very similar appearance as well. I want to show you this case of nocardia as well. It's pretty rare disease. This is a patient, a 58-year-old patient with history of pulmonary alveolar proteinosis, which was complicated by nocardia pneumonia. And I want to show you that because this is very a dramatic presentation of disease, and we should keep in mind this disease in immune-compromised patient. So looking at the HRCT, multifocal disease, areas of ground glass attenuation, significant interlobular septal thickening, mass-like opacities, and those thick-walled, irregular cavitary, mass-like cavitary lesions with the fungus within them. This is after treatment 7 months later with Bactrim, shows decrease in size of cavities and ground glass opacification. The diagnosis is made by pathology, endobronchial biopsy or sputum analysis. And the nocardiosis filamentous bacteria infect organ transplant recipient. Long-term steroids for COPD, it's inhaled or aspirated from soil, results in pulmonary nocardiosis. I wanted to show you this case as well, Rhizopus infection in the 57-year-old male with renal transplant, progressive invasive mucormycosis. So this is even more dramatic case. As I mentioned in the previous one of the previous fungal infection cases, that those do not respect anatomic boundaries. They do not respect any the tissue characterization, so they really eat through the chest wall, create multiple fistulas, and this is multi-organ infection. It involves usually sinuses and create those create those large masses and non-healing fistulas in the chest wall. the last infection that I want to cover is Mycobacterium. It's basically MII. Everyone is familiar with this, so I left it for the last as the last disease. But it is important to mention because we see that a lot, and not necessarily only in the immunocompromised patient, but we should remember about the variety of MAI and MAC presentation. So this is a 33-year-old patient with a history of ALL, post-allogenic peripheral stem cell transplant. She does have GVHD of the skin, mouth, eyes, lung, and vagina with MAI infection of the lung. So look at those multiple ill-defined, irregular, thick wall cavitary lesions that are similar to the other fungal infections that I showed you. So when we see something like this, do not forget about MAI or MAC. That we still see the ground glass attenuation present around. We see those not particularly characteristic as we used to see in bad nodularity or ABPA cases, but this is the case of invasive disease in immune-compromised patient. Here is the post-treatment with the fuzzy nodules, bad nodularity, more characteristic appearance that we usually see in immune-compromised and immune-competent patients as well. I want to skip that so to leave a couple of minutes for questions as well. So take-home points in pulmonary infections in cancer patients. These are very dangerous. These are the source of significant causal morbidity and mortality. They are dependent on what arm of the immune response they affect. There's some link to the type of disease and type of infections they cause, but there's a lot of overlap, and then we should be remembering about those rare diseases that can happen in immune-compromised patients, particularly those fungal infections as well. So with that, thank you very much for your attention, and this concludes my talk.
Great, thank you very much, Luba. So if anybody has any questions, they can put them in the chat. We have a couple of minutes left for questions. So I do have one question, which I believe is for you, Mizuki. I think it's from Martha Braschi at the Leahy Clinic in Boston. Can you speak to the timing of pneumonitis flares?
Yes, that's a great question. And so as I show in some of the representative cases, in my experience, they tend to be like several weeks after completing steroid taper. That's so it's probably like a few weeks to at most several months. But this is because there is some selection bias. So this is because it's very difficult to, if it's longer than a few weeks, then multiple other factors can happen, such as ICI rechallenge or new therapy or some other maybe infection. So that becomes very difficult to purely diagnose that this is rebound or pneumonitis flare due to rebound without any other exogenous stimulus. So there is a bias, but in my experience and some of the record that we do see, it is a few weeks, 4 weeks plus minus after completing steroid taper. But the length of steroid also depends on the patient, and these clinical courses, after once pneumonitis happens, it really depends on, there could be a tumor progression. So it really depends on the individual patient. It becomes very difficult to collect those cases and come up with a definitive number. Thank you.
Great, thanks, Mizuki. So I don't see any more questions, and I think we're just about at time. So do either of you have any closing remarks on cancer imaging in the chest, thorax, lung?
No, thank you so much, Fiona, and it's great. It is great that we covered completely different angle of looking at chest of cancer patients, but both are important aspect to know about novel therapies, but also infections that comes toward the end of this end of the spectrum of patient journey. And yeah, it's great that I really would like to thank Fiona and ICIS staff and for this opportunity. Luba, would you like to say something?
Yeah, I just wanted to thank for this opportunity. I hope that our participants learned or enjoyed the session, and that there are many more sessions that International Cancer Imaging Society offers. that are many of them are free, and then you're welcome to participate. Thank you for your attention.
Thank you both. So just to remind everybody that this session is recorded and to check the website regularly for any updates on new courses that are being offered. And again, just a brief reminder that the deadline to submit abstracts for the ICIS meeting in Singapore is May 31st, so the very end of this month. So thank you both, and thanks to ICIS. Bye-bye.
Thank you.